and testing, while it's better than it was a month ago, is falling behind and not really able to meet some of the rhetoric going around that there be multiple testing of patients and residents of these facilities throughout, say, a week. And even if they were tested frequently, the turnaround time for testing is not really on par with being able to do that efficiently. So the scale here is quite large. There are about, as far as the, I think May 14th, they were saying that cases, only from reporting 38 states, there are about 152,000 cases in long-term care facilities and over 30,000 deaths in 35 states reporting just at the national level. And so that's definitely concerning, and that it bears out at about 18% of total cases in North Carolina, for instance, are from long-term care facilities. So this is definitely a big concern as well.
Gotcha. Thank you very much for that. So Professor Taylor, I'd like to move on to you. You are predicting that the situation at nursing homes is likely to get worse before it gets better, especially when winter comes. What are some of the factors that are fueling that, and what could be done to address it?
Yeah, that's not a particularly bold prediction, probably, because I think the best way to think about nursing homes is to think about the people who go there every day. And that includes the workers, and workers in nursing homes are at risk of occupational exposure. They also are at risk of bringing infection into the nursing home from community and taking it out. And so when you have people moving in and out, and we already know we have lots of infection in nursing homes, obviously that in many ways is the place where the epidemic is really, hot. Professor McConnell is going to talk about long stay residents of nursing homes. When I was mentioning what I suspect will come in the winter, nursing homes also tend to have numerous people with short stays. So, for example, if your mother falls and breaks her hip, slips on the ice in the winter, goes and has her hip fixed, very commonly, she may then need to go to a skilled nursing facility, a nursing home for, say, a week or 10 days of rehab. So that's another source of people moving into nursing homes. So it's basically, nursing homes are places, but I think if you want to think about and understand COVID-19 in nursing homes, you need to understand that you have patients who are at risk moving in and out. You have long stay patients who are at extreme risk who are there, and you have workers moving in and out. And really, I think without a broad scale asymptomatic testing approach, we will not deal with the epidemic in skilled nursing facilities.
Gotcha. Thank you very much for that. So now, Professor McConnell, I'd like to move on to you. We're in a period of social distancing. How is that in particular affecting residents of nursing homes? And what can the workers caring for them do to mitigate those effects?
Right. So I want to begin by thanking you and the people, the media presence today, for taking time to address this really important issue. I think before I answer your question, Greg, I just want to take a moment to recognize and honor the incredible contributions of the staff in nursing homes. As both Nathan and Don have mentioned, they're in there every day doing incredibly hard work under very challenging circumstances, a lot of uncertainty, and I think they deserve every bit as much honor and respect as their counterparts in the intensive care units and emergency departments. But to answer your question, I think in addition to the infection control and the masking that makes the workers' job more challenging, it also makes it harder for the people who are living in the nursing homes to carry on their day-to-day activities. We've suspended congregate activities such as mealtime or the ability to engage in group activity or even walk around the building in a natural way. And that has taken its toll on people, and I think will continue to take its toll. So what I can say about opportunities to enhance social engagement are, there are three things that I think nursing home staff can do regardless of the resources that they have. The first is to continue to partner effectively with family members to better understand what matters most to the individuals. As Don's already said, these residents are incredibly high risk for infection and for adverse outcomes. And so now more than ever, we really need to understand and focus on what matters to the people who are living in these nursing homes. Second thing they need to do is make better use of technology. There's a whole range of ways in which we can connect family members who can no longer visit with the residents in the nursing homes, from simple technology like the telephone to more advanced technologies like a Zoom platform. But we need to help the staff get the administrative support they need to implement these technologies and do things like schedule visits with family in much the same way that they schedule basic physical care. And then finally, research has shown that people of all different levels of cognitive ability retain the ability to display emotion. And I think staff need to be particularly attuned to emotional response of the residents living in these communities, because oftentimes it's only through emotional expression, be it the ability to express joy or sorrow or fear, that we're going to successfully meet both the psychological and social needs as well as the physical needs.
Gotcha. Thank you very much, Professor McConnell. And to all of our panelists, we've got a great opening there. We're trying to cover this from as many angles as possible. We're now going to move on to questions from reporters on the call. So as I mentioned, if you are joining us on Zoom, you can type a question into the Q&A and we'll see that and address it. You can also raise your hand by hitting the raise your hand button, and then we can unmute you so you can ask a question. If you are joining by phone, you can press *9 and that will also raise your hand and then we can unmute you. So feel free to go ahead and submit questions as you have them. We do have some pre-submitted questions, and so we'll start with that. And Professor Taylor, I think this one might be best addressed to you. We have a question from Sharon Van Zwijten at Spectrum News, and I'm guessing this is a North Carolina question. And she asks if workers are getting any kind of rapid testing or screening before coming to work, and if not, are there plans for that? And so do you have any sense at the state level or even nationally what is in place or what might be coming?
So it differs by state. Some states have announced programs that say there's mandatory testing, but exactly what that means, meaning what type of test, how often the test is done, is still extremely uncertain. In North Carolina, I'm not aware of, there's no set protocol for that. I am, along with some Duke colleagues, we are trying to convince several chains of skilled nursing facilities to join with us to undertake an asymptomatic testing of workers in nursing homes, and do this in a way via randomized controlled trial to actually collect evidence for what works best. So I think most people probably are getting around to thinking we have got to get there. We are not there yet. We need to do this in a way that helps us learn and collect evidence, in one sense, to get ready for next year's flu season, when this will, because it's always worse in nursing homes during flu season. So that's not a new thing, it's an old thing.
Gotcha.
Yep.
Sorry. Professor Boucher or McConnell, do you, either of you, have anything to weigh in there on the testing of residents or workers?
Yeah, I don't mind going ahead quickly on this. The big problem here is the disjointedness. We've been throwing around the word skilled nursing facility and nursing home, but there's all sorts of skilled, levels of skilled nursing facilities and nursing homes and assisted living facilities and care homes and residential homes, and the oversight varies. It's credentialing of these facilities and regulatory oversight and credentialing of the folks within who are the staff happens at the state level by and large, but they're getting any manner of Medicare and Medicaid dollars. And so some of the, feet being held to the fire, if you will, like Monday's CMS relaxation of restrictions based on the following, A, B, and C points that they have, which they published on Monday, that may or may not apply to each and every one of the facilities along the long-term care services and supports system or continuum. So, so there's varying degrees in ownership of these organizations or facilities, oversight, both of the facility and of staff. And so that creates a lot of disjointedness in rolling out some of these programs. And I do believe that there needs to be, because this is not just statewide, it's not a state problem, it's a country problem, that there needs to be more federal input on this, at least in dollars, and allowing the states to coordinate at the ground level with individual facilities.
Gotcha. Thank you very much for that additional context. We have a hand up among the attendees. So if we can go ahead and unmute that person. And once you're unmuted, go ahead and tell us who you are and who you're with and your question, please.
Hi, this is Jennifer Abbasi from JAMA's news section. I'm wondering if there's data yet on associations between nursing home factors and nursing home COVID-19 outbreaks.
Do you mean like star ratings? Is that the type of thing you have in mind?
Yep, and also size, location, demographics, things like that.
Yeah, there's I don't believe we have systematic evidence about that. You have there have been a series of expose type news stories. Some of them I think have been unfair in the sense of these systems that we have to care for the elderly were in many ways, as Nathan was talking about, fragmented, difficult to start with. So a novel infectious disease introduced into them was always going to be like somebody throwing a match to a can of gasoline. So I wouldn't be surprised if there may be some differences that emerge, that perhaps some facilities that had trouble with infection control may have more trouble. But the reality is one asymptomatic worker or one asymptomatic patient coming in can undo, the best infection control, unfortunately.
Okay, thank you.
Did any of our other panelists? Professor McConnell, you have something to add?
Yeah, I'd like to add to that. I agree with Don that I think we've got to be very careful not to blame the victim here and, bash nursing homes for not anticipating something that none of us have anticipated particularly well. That said, I think as we gather more systematic data, and I think there are advocacy organizations such as Friends of Residents in long-term care in North Carolina who are starting to put together the story of probably a relationship between underlying or baseline quality and the ability to stand up appropriate infection control procedures. I agree with Don. I don't think those data are in yet, but I think they will be forthcoming. I also think there may end up being some relationship between some of the nursing homes that are either affiliated with larger health systems and able to collaborate with them around standing up appropriate infection control protocols, or the sort of professional bench depth, if you will, for people who can make sense of this rapidly emerging sets of guidance.
Gotcha. Thank you very much for that. And Mr. Bussey, I hope that answered your question. We're going to move on now. We have a question in the Q&A from Celeste Gracia at WUNC. It's kind of a related question, so we'll see where we go with this. How come some facilities have had larger outbreaks compared to others? What factors go into a smaller or larger outbreak? Does it have to do with the staff-patient ratio or prior sanitation practices or other factors? So that's a multi-part question, but can anybody speak to how there's been this variance between facilities regarding outbreaks?
I can begin and say, I think the truth is we don't really know yet. This is just unfolding so rapidly, but we can certainly speculate. And I think if you just get very concrete and think about what does it take to implement basic infection control procedures, it's time consuming to mask, to gown up, to wash your hands. And it stands to reason to me that if you're starting out with a very thin level of staffing, that it's going to be hard to take those precautions and continue to provide what's very demanding care. So I think that's going to be an important variable, but I think we just don't know yet.
And I think that I agree with that we're still discovering what might be related to differential outbreaks, but I think there's also, given asymptomatic transmission of the disease, that we probably will not be able to get control of this in nursing homes without asymptomatic testing. And we don't know what that protocol of testing, like how often, what type of test needs to look like, but we desperately need evidence. And I believe if we don't manage to control the epidemic within nursing homes, we're not going to control it in the United States.
Yeah, thank you, Don. This is Nathan Boucher. Just really quickly, understand that these facilities are not closed systems. There's a constant flow of shift workers in and out of these systems every hour, every shift. And even though there's no visitor policies, there are staff that go out to the community and come back in again. And so even if they're really up to snuff at the facility level about what they do internally, there's an awful lot that goes out in the sort of wild west of society, and depending on where these folks live. And some of them work other jobs. Many of these care workers work other jobs. They are caring for their own family members. There's a lot of contact going on before they hit those front doors.
Gotcha. Thank you, panelists, for that. I would remind everybody on the call, you can submit questions via the Q&A window. You can also raise your hand, and if you're on a cell phone, you can do that by hitting *9 to keep those questions coming in. But we do have additional questions, and one here, what are some of the special challenges for patients with dementia during the pandemic? Or if anybody can kind of address some of the particular challenges there.
So I'd be glad, this is Eleanor McConnell, I'd be glad to get us started there. I think one of the challenges that people living with dementia have is that as a part of the brain disease, there's often difficulty in communicating, understanding instructions that other people give you, or remembering about things like hand washing or social distancing. So that's one important factor. I think a second is that people who have moderate to severe dementia require or depend upon nonverbal cues to understand someone's intent. So if you can imagine having to communicate on a day-to-day basis with all these people with masks on, that to me is a big lift and a real challenge. And then I think the third challenge that I see is there's this notion in dementia care of emotional contagion. And I think if staff are anxious and fraught, there's likely to be some transmission of that emotion to others. And I know from talking with my colleagues in acute care that as they've become more comfortable with managing COVID-19 and trusting that they have safe environments in which to work, their anxiety has come down. So there's part of me that's a little hopeful that this can get better, but I think the challenges are particularly important for people living with dementia.
Thank you, Professor McConnell. Just giving our other panelists a chance to weigh in if you've got anything additional to add on that.
My mother-in-law has dementia. Everything's harder for somebody with dementia. Often, I think Ellie walked through a lot of the examples, but it's also a lot of strain on the family members. So routine is very important for people with dementia. And I just know in the case of my mother-in-law, she's wondering why her daughter can't come. And so this makes everything more difficult. And it was hard to start with.
Absolutely. And that actually rolls us into another question that we have, is that obviously family members are often the strongest advocates for care for their loved ones. How can families best advocate for their loved ones, in a time when they can't physically visit? Are there any kind of recommendations that you have, or any perspective you can give on the particular stresses for family members right now?
I just say my mother lives in a continuing care retirement community, and she's on the precipice really of independent care, really moving towards assisted living. And we have actually chosen to hire people to come into her independent cottage to avoid having to move her within the facility into the residential part of the unit, in part out of, worries, SARS-CoV. I think we have talked, my mother's learned FaceTime, so that may sound weird, but I used to talk to my mom by telephone, and now I FaceTime her, and she started FaceTiming my children. And actually, it's opened a new mode of communication that's been a positive. So I'm not sure why I never thought of FaceTiming with my mom, but it has, at least in our family's case, taken some of the sting out of the not being able to visit. On Mother's Day, I did go and visit her, and I sat outside her her unit, and we chatted, from about 10 feet apart. They had not been allowing anyone even to come onto the premises before then, and on Mother's Day, they had allowed this. So that's just examples. That's just a personal example.
Sure. Professor Boucher, you've written about how the effects of the pandemic on caregivers. I'm sure you can weigh in on this too.
Sure. Yeah, I was just about to pipe up. So this is Nathan Boucher, and so definitely, I think harnessing the full extent of telephonic and online virtual communication would be really key. However, a key component, not so much in telephone, but with virtual visual communication, would be internet connection and Wi-Fi available potentially at those facilities, plus the hardware to potentially do that. So, if one facility has one iPad, if they're lucky enough to have one iPad that goes around from patient to patient, there's A, infection control concerns there. B, that's not adequate for possibly hundreds of residents who might want to be virtually connecting with their friends and family. And so I do believe that hardware and Wi-Fi connectivity, which is a problem in many of our communities, would really enhance these efforts and take full advantage of that technology to keep people connected.
And Greg, this is Ellie McConnell. If I could weigh in on that as well, I agree with Nathan that this issue of internet connectivity and access to devices is really important. I'm happy to report that I know at least some of the advocacy organizations are starting to try and move on that front through taking advantage of civil monetary penalty funds to support this type of effort. And so my hope is that CMS will act briskly on that, since we have quite a bit of money in the North Carolina CMP fund that could help to address that. The other thing that I'd like to amplify is this idea that while facilities may have only one iPad right now, that could change quickly. I heard some of my colleagues in acute care talking about how an iPad is now just another piece of medical equipment, that they've figured out how to work into the workflow. And if you can do that in acute care and manage the infection control there, you ought to be able to figure that out in skilled nursing care and assisted living as well. So the last thing I want to say is to Don's point about both family and facility staff being incredibly creative about how to bring people together. I think there's an erroneous thought that old people can't do technology, and that's simply not true. The devices have gotten sufficiently simple that that's a viable alternative if we pay attention to the issues that Nathan raised around bandwidth, access to Wi-Fi, and dealing with rural communities who are particularly challenged in that regard.
Absolutely. Thanks so much. And great to hear from all three of our panelists on that question. We have another question, and I would remind again everybody on the call that you can ask questions in the Q&A window, or you can raise your hand digitally or using *9 if you're on a phone, and we can unmute you so you can ask a question. But we'll move on to some of the questions we do have. Professor Taylor, you mentioned earlier that we won't control the epidemic in the US without controlling it in nursing homes. You've mentioned the need for testing, but what else exactly needs to happen to control the epidemic in nursing homes? I'm wondering if you could dig into that a bit more.
Yeah, so if you use North Carolina's example, less than 1% of the population lives in a nursing home today. Between 15 and 25%, the new cases are folks living there, and probably half or more of the deaths, and we're probably undercounting. So just probabilistically speaking, you could think of homes as places where people are particularly vulnerable, but they're also wells of infection. And as we've now talked, we have patients moving in and out, especially for short-term rehab, and we have workers moving in and out. And again, the workers are at risk of occupational exposure, but they are also a risk of a vector of transmission to bring SARS-CoV-2 from the community into the nursing home, and from the nursing home back to the community. So in my mind, I feel like our country does the ability to focus on anything for very long. If I could pick one thing that we would focus on for the next 6 months, it would be to say we have got to undertake asymptomatic testing on a systematic basis in nursing homes, and both to protect the people living there and to see if what we can do to potentially push the transmission rate below zero countrywide. So I'm not sure we could push the transmission rate nationally below zero by focusing only on nursing homes, but I can't think of any other place with such a concentrated, let's just call it well of infection, other than, prisons and perhaps some of these, we've seen outbreaks in meat packing plants.
Gotcha, thank you. Just giving our other panelists a chance to weigh in on that question, if either of you have any thoughts too.
Yeah, this is Eleanor McConnell. I have two thoughts. One is, I think some of what Don is talking about, while it may seem extreme because of the challenges around adequate numbers of tests and whatnot, I'd like to remind people that we have models for doing this already in occupational health in healthcare. We routinely screen people for tuberculosis, and there are, state level, federal level mandates for that. So I think there are models we can build upon.
Yeah, thank you, Ellie. This is Nathan Boucher, and I also just want to add to that, a lot of the infection control and the ramping up of best practice in the acute care hospital system has been in the news, but it's tenfold more difficult to do in some of these facilities, which sit remotely from a larger medical center, most often don't have their own internal labs, so they outsource all their lab testing. They're just more isolated in the community. Even if they are down the street from a world-class medical center, they may or may not actually have an affiliation or memorandum of understanding with those larger world-class facilities that could even advise them or help advocate for them, or they have rounding clinicians who also see patients at the large tertiary care medical center. And that's even worse for a smaller nursing home or skilled nursing facility that's quite rural and away from some sort of larger urban center where a lot of that best practice and research is taking place and the media is focusing on. So I definitely I want to highlight the sometimes inability of these more remote or smaller or only Medicaid receiving facilities that just may not have the resources for both their staff and their patients.
Absolutely. Thank you all for that. We have another question here that I think Professor McConnell, you might be best placed to tackle first, about how we're moving, at least in North Carolina, towards reopening, but nursing homes certainly don't seem to be at a place where they can be involved in that. But how are nursing homes folding into reopening plans, or how should they?
That is, to me, the $64,000 question here. Right now, as I read the guidance about phased reentry, nursing homes don't even appear on the agenda, and I think that's shameful. However, I think some of the discussion we've been having about nursing homes, because of the way they are staffed, being particularly challenging reservoirs, it may be appropriate right now until we figure some things out, but I don't think it's acceptable to just wait or ignore the fact that we have to have some kind of plan for reopening. But quite honestly, I think we need more systematic data to answer the questions that were raised at the top of the webinar regarding what are the factors that influence control of outbreaks and control of infection. And I think until we have those, it's going to be tough to figure out a systematic approach for reopening. I think we're going to be living with this, coming up with creative solutions to very challenging problems for a good while to come. But I'd be interested in hearing what my colleagues have to say about that.
Yeah, a local skilled reached out to myself and one of my colleagues asking, could they implement a testing approach to allow family members to get back to the bedside of loved ones, because family members are really important parts of the delivery system, even for people living in nursing homes. That they're there often to help provide care, and they're very important for the emotional and mental well-being of the patients. And so they were basically saying, could we try to set up a study and provide symptomatic testing for loved ones? And I think technically that can be done. It's, I think what Ellie said is very important. We are going to have to learn to deal as best we can with risk, but there are going to be more risks than what we've been used to living with for some period of time until we have either a widely available and safe vaccine or a treatment that really changes the course of the disease. So I think asymptomatic testing for nursing homes is super important.
Right. Thank you, Don. This is Nathan Boucher. And so, on the 18th, on Monday, CMS, Centers for Medicare and Medicaid Services, came out with the following guidelines. They wanted, following related to reopening, they thought that nursing homes and skilled nursing facilities should be lagging behind in reopening by about 14 days. Also, it's really important if they had a recent outbreak in that particular facility, because that would come into play. So considering those first two things, along with 7 other items, which is what is the community's case status outside of those walls of that facility? What is the nursing home case status? Do they have adequate staffing? Do they have a good local hospital that has capacity to take them on if patients get too sick to be in that facility? Do they have universal source control? That is, do they have enough PPE for both patients and staff to wear? And do they have of course, adequate testing? And then that's a huge one, as Don just highlighted.
Thank you all very much for that. We have another question that is a perfect follow-up to that, because all three of you just touched on it. Don had mentioned earlier about the need for widespread testing, as Professor Boucher just mentioned. But what would it take to focus on that nationally in the way that it clearly needs? Is it simply a matter of supply, or are there more factors at play there?
So, I mean, for what it's worth, I think really we need a federal effort, at least monetarily, with to push more testing. So we, basically we totally squandered February. In April, as a country, we started up and we kind of plateaued. It looks like we're ramping up again, but there's going to take focused, I think, federal effort, at least with money, to help get to the level of testing we're going to need. And then I think each state probably should be responsible for working out the approach of how testing will work in that state. Because as Nathan mentioned earlier, one of the realities of caring for elderly folks in the United States is there are tremendous differences by state and great discretion given to states with regulation. So I think it's going to take focused federal money and state level oversight.
This is Ellie McConnell. I would add to that or underscore the importance of the state and local efforts. I think here in North Carolina, we're fortunate in that we have good leadership at the state level, both gubernatorial as well as at Health and Human Services. And we tend to have pretty strong health department leadership as well. And so I think one of the things that will be required is a set of strong practices from places that have more effective public health apparatus in the first place to sort of show the way for other states. But I think it is going to be this combination of federal and state and local partnership to get the job done.
Okay, thank you guys very much for that. And actually, Professor McConnell, you kind of led us into another question that we have. And before I ask this, I will give everybody one more chance to write questions into the Q&A window, or raise your hand either digitally or by pressing *9 on a regular phone. But we have a question about North Carolina specifically. And so I guess one of the things we're wondering is some of the specific challenges in North Carolina, especially given the urban and rural divide, and what the state needs to do over and above whatever it's already doing, or what could it be doing over and above what it's already doing in order to help these facilities.
I think, again, there are a lot of efforts going on that are a little bit under the radar to help facilities. And a good example would be the partnership between Duke University, the Orange County Health Department, when there was an outbreak at the Pruitt Nursing Home in Orange and Durham County. And the story that I heard was there was a very rapid and effective response to get testing done. And so I think that's an example of what we need to see more of. In the same way, our accountable care organizations in North Carolina, and we have many, are potentially an avenue to get nursing homes the help they need. And at least in the Duke ACO, we've seen a lot of very strong collaboration among nursing homes that are both in the what we call the northern tier, more rural areas of North Carolina, as well as here in the Triangle area. So I think those are examples of responses. I think the other thing that we've spoken to, but bears repeating, is this idea about focus, focus, focus. Unless we really focus on people who often have limited access to healthcare, such as healthcare workers in nursing homes who may or may not have adequate health insurance, we're going to need to attend to that if we're going to get to the level of testing and appropriate follow-up that has been discussed earlier.
And I think we need evidence generation. Like I think the state can say we need testing, but we actually need to know is, do we need, pharyngeal swab sample, or which requires PPE for someone to collect it, or can people self-collect? Like we need to understand, the practical realities of how well the testing works under real world conditions. But in general, the nursing homes need, more and better PPE, and access to testing is part of this. I think in the rural parts of the state, as Nathan was saying, you could be down the street from a large facility and not be allied with it, and out in rural areas, you're just all the further from support, essentially. PPE and testing, and doing all of that in a way that actually generates evidence, because there are a lot of really simple questions that can, but giving an evidence-based answer to them is still really difficult.
Yeah, thank you, Don. This is Nathan Boucher. So, we have a particular problem as far as deaths in nursing homes, nursing facilities as a share of total deaths in the state. Is that as of May 14th, and this is may have changed by now, but May 14th, 61% of the deaths in the state were in long-term care facilities, whereas nationally that's 41% in long-term care facilities. I actually envision somebody from the U.S. Public Health Service, possibly FEMA, possibly the State Medical Reserve Corps, showing up with a truckload of PPE and having one of those individuals as sort of an infection control czar in each one of those facilities, who can have the 30,000-foot view of what infection control practices are having, or what's the status and how can it be improved, conduct staff trainings, get them up to best practices, and make them feel and give them actual support with both supplies and advisory capacity. So I would sort of envision, a U.S. Public Health Service officer or Medical Reserve Corps officer, with a truckload arriving at each one of those facilities to really get on the ground.
Gotcha. Thank you, all three of you, for your responses there. We do have a raised hand once again. Jennifer Abbasi with JAMA Network. You're unmuted, so please go ahead and ask your question.
Thank you. I actually have two questions. The first is sort of a basic one. So what currently, until CMS and CDC releases the numbers on nursing home infections and deaths, which they've said they're going to do, I think in a couple of weeks, what currently is the best source of those numbers, the most reliable source, and the ones that researchers like you are using? And the second question, maybe you can go ahead and answer that one first.
Well, this is Nathan Boucher. One source that I've been using, overall for COVID cases across the nation, the Johns Hopkins group is really been top notch when it comes to specifics on long-term care deaths and cases. One website that we've been referring to is the Kaiser Family Foundation's long-term care statistical database, and that gets updated every week or so. So that those are some resources.
And I think in a state like North Carolina has been pretty good about reporting the data. So we've got reasonable data for that in this state. The problem is if you want a national number, almost it's going to be an undercount because some states are not releasing the data. So if you see a state level measure, the first question to ask is, are they reporting by location of death? And if not, it's going to be undercounting long-term care or nursing homes. And nationally, any national number is going to undercount.
Yeah, definitely understand there's a long-term care services and supports continuum. So it's a loaded term to say long-term care facility when there's so many different kinds that fall under the jurisdiction and pockets of funding that they might rely on. So there's a lot of different pieces to making that one statement about long-term care facilities, quote unquote.
Yeah.
Am I still unmuted?
I think we, Jennifer, I think you started talking, but then we dropped you. Are you still there?
Yep. Can you hear me?
Oh, yeah, we can hear you now. Yeah, please
Okay.
go ahead with your second question.
Regarding what you just said, Nathan, is there the expectation that the federal data that's coming will report based on type of long-term care facility?
I hope that it will. I don't have a lot of faith that we'll get that granularity, but I'm hoping we do, because that'll allow us to target in a very real way. So if a facility has oversight from the state, from both facility level and credentialing of its employees, but it gets its funding from Medicare, then Medicare comes out with guidelines. They can hold their feet, that facility's feet to the fire, and give them a framework to draw from. But if that facility is not receiving a particular bucket of money, then that oversight may not exist. That incentivization may not exist quite the same way. Just there are a number of residential care homes out there that may just have 10 people there. There are a number of nursing homes for long-term care. There's subacute facilities and assisted living facilities, which might be a lot of private pay individuals. So I do hope that we get that parsed out in that data, but also understand that because there's so many different kinds, that they may not all be required to report to the state and then federal level.
Yeah, if a facility receives Medicare and Medicaid, eventually we'll probably count that with some precision. But especially like in North Carolina, we have what are called rest homes. And I think they are facilities with fewer than, 12 residents, and they're very lightly regulated. They don't, they're not able to bill Medicare and Medicaid. So the only way to capture sort of information, to do it fully comprehensively along the full continuum of long-term services and supports, that's going to have to start in kind of the old school county health department, aggregated up to the state death certificate reporting data. So that will not be done via CMS.
Gotcha. Thank you, guys. I hope, Jennifer, that answered your question. As we move towards wrapping this up, we'd like to kind of refocus on the human element here. And we've got a couple of questions that do that. First of all, what are some of the particular stresses on care home workers that maybe we haven't touched on? What are some of the hardest things for them in this situation? I know obviously there's the risk of infection and so much going on, but can we kind of speak to the plight of the workers right now for a moment?
I'd be happy to start. Excuse me. In addition to what you've just said, Greg, I think there is this added time to implement these infection control procedures, and time is very precious in long-term care because the needs are enormous. I think the second is the challenges that the masking and the social distancing create for the people who are living there. And the staff that I know are very compassionate people, and they feel the pain of the residents for whom they care. So I think there's a little bit of feeling of hopelessness or stress around, under ordinary circumstances, may know how to support this resident, but right now I've had my toolbox emptied by all these restrictions. And then I think the third is just all the uncertainty about how long will this go on, and what are my risks in various places. Since it's been said earlier, many of these staff members will work in a home care agency as well as in 1 or 2 different nursing homes.
Yeah, I think workers are worried about getting their families sick. They're worried about making their client who they're caring for sick. And they're worried about if they get sick and they don't have paid time off, who's going to pay the bills. So the system of caring for the elderly in the United States goes through people that touch our parents and grandparents every day. And they are not paid in accordance with how important they are to the vitality of helping those folks live as best they can. That was true before this happened. This has just opened that up and laid bare the inadequacies of the systems that we have.
Right. Just to echo that, this is Nathan Boucher. These are longstanding issues: the under-resourcing, the underpaying of employees, the low reimbursement rates for this highly valuable but underappreciated care. So here we go. It's all hopefully some of the upshot in this atrocity is with the pandemic is that it is coming to light like it hasn't been before, and that's certainly my hope, and I'm glad we're doing things like this to add to that.
Gotcha. Thank you all very much for your perspectives on that. And staying in the kind of human element, we talked about some of the challenges for families of people in residential care right now. And so one of the questions we had is what's one thing that families should be doing or thinking about the most as they try to support their loved ones who are in residential care?
I'll start and say I think it's all about relationships. So we talked earlier about family staying connected with the nursing home staff, be it the administrator, the social work staff, but increasingly I'm hearing nursing homes talk about a new class of worker, which is a social connector. Recreation therapists who used to be connecting people in groups now are connecting people on the phone. So I would encourage family members to step up, and if they don't already have a relationship, use this time to forge one, because it's going to be really critical in the days and months to come.
Yeah, I think the key, just in terms of thinking about with my mother and then my mother-in-law who lives in a different level of facility, it's actually been to increase communication when in-person visits have gone away. So I think it's important for your loved one to have an advocate, and if you need to try to stay as engaged as possible. And it's hard.
Yeah, thank you, Don. And this is Nathan Boucher. I just want to add too that outside of people's families, because sometimes they may not have family around or friends who are able to connect with them on some level or support them even at a distance, that there are a number of not-for-profit organizations and area aging agencies throughout the nation, and definitely in North Carolina, who are organizing reassurance calls and other ways that volunteers who may not be friends or family of some of these residents, and even in the home care sector where folks are living at home but still isolated and getting some limited nursing type of care at home, that there may be opportunities for students on summer break, high school students, college students, other volunteers to do virtual calls or telephone calls to help with some of that, to mitigate some of that social isolation. So there's opportunity for society at large that may or may not be friends or family to these individuals.
Gotcha. Thank you again, all three of you, for giving your perspectives on that. We are close to time, so I'm going to ask one more question of everybody, and then we'll wrap this up. And I think, one of the things that this pandemic is doing is obviously changing the world for the long term. And so I think one of the things that what I'd like to know is, and this is also an opportunity for you to re-emphasize something, a point you may already have made, is what's one way that this is going to change residential care in the long term, beyond just this immediate pandemic? What kind of changes could we see that we'll just have to get used to, or should get used to, for the benefit of everybody involved?
So this is Nathan Boucher. And so I would say there's probably a number of negative things, but I'll just add a positive thing in that, just like in regular healthcare and the rest of society, we've done the organic societal experiment to see if things like Zoom and other virtual remote connectivity options actually work. We've sort of been forced to use it and work out bugs. I'm hoping that that will become a regular thing, even if things go back to quote unquote normal from a perspective of isolation in these facilities, that there will be regular use of not just telehealth for clinician types of visits or clinical duties, but also to mitigate some of that social isolation that we've been talking about, because that just was a problem before COVID-19 and it's just worse now. So I'm hoping that technology will rise to meet the occasion. We won't just leave it behind because that's no longer a tool that's useful because of isolation. It should actually continue.
Go ahead, Ellie.
This is Ellie McConnell. I think that I agree with Nathan that telecommunication has a potentially transformative effect. I guess the other hope I would have in a positive vein is that we would actually take much more seriously than historically we have the role of the workforce in long-term care, and consider things like institutionalizing a living wage so that there isn't the risk of people needing to have multiple jobs in order to make ends meet, and also recognizing the critical role that these staff play, not only in the basic physical care, but also in the promotion of well-being among these people. They're stepping up like never before, and I hope we will honor and support them as they continue to do that important work.
Yeah, I think there's long been what I would call a learning problem in how we care for the elderly, and that could be synthesized by mother only dies once. And by that, I mean, you don't get to practice it. You don't get to do it 100 times and learn how to be a good advocate for your mom. You can only do it one time and do your best you can. And then usually when first pass, the last thing people want to do is think more about long-term care. They're like trying to recover from it. And I think, so it's often been a silent, perpetual, repetitive series of problems that researchers say, oh my gosh, people just keep rediscovering the same thing and we never seem to be able to do anything about it. I think that COVID-19 broke into the national consciousness through a nursing home outbreak in Washington State. And so maybe the vividness of how bad it's been in some of these homes nursing homes may potentially lead to some changes, and for us to just understanding how important this part of our society is to each of us. So hopefully we'll have a safe, effective, and widespread vaccine, and hopefully we don't forget that we still have lots of problems with how we care for elderly folks in the United States.
And thank you, Don, very much for that. We are going to leave it there. All that remains is for me to say thank you to all of the reporters who joined us on the call, everybody who was watching on YouTube, and most of all our panelists, Don Taylor, Ellie McConnell, Nathan Boucher. Thank you very much. Our next briefing is scheduled for May 27th, when we'll be addressing the pandemic's impact on the Latinx population in the US. If you'd like to be included on the advisory for that event, please email dukenews@duke.edu. In the meantime, thank you very much for joining us, and please stay well. Have a great day.
Thank you, everyone.